Alright, so next up we're going to cover shock. Shock is extremely high yield and is defined as a reduction in systemic perfusion pressure resulting in poor oxygen delivery to organs. Initially, it creates reversible ischemia, but if it continues, it will soon progress to irreversible end organ damage and potential death. Now, there are four main types of shock: hypovolemic, cardiogenic, obstructive, and distributive. Now, no matter what type of shock we're talking about, the underlying physiology is the same, because cardiac output and systemic vascular resistance determine tissue perfusion. Our job here is to distinguish which type of shock is decreasing one of these two variables, and then how we're going to treat it. And remembering what the primary problem is for each of these types of shock will help us in this process. Alright, let's get started discussing each individual type. We'll start out with hypovolemic shock. So in hypovolemic shock, you're going to have a decrease in the intravascular volume. This is either going to be from hemorrhage, dehydration, or even burns. Now, burn patients might be a little counterintuitive here, so just remember that burn patients lose their skin barrier and have a very leaky vasculature due to excess cytokine response. All this leads to overall volume loss, and hypovolemic shock can ensue. So what happens when we lose a bunch of volume? Well, this is going to result in a big drop in our preload and our central venous pressure, and this is just because there isn't enough blood in the veins. Now, I know on my chart here, I have the pulmonary capillary wedge pressure listed. And what you need to know is that pulmonary capillary wedge pressure and preload are essentially synonymous. So if you have a drop in your preload, you have a drop in your pulmonary capillary wedge pressure. Now in hypovolemic shock, when your preload, your pulmonary capillary wedge pressure, and your CVP all hit the floor, you're going to obviously have a drop in your cardiac output because you can only pump what goes into the heart. And if nothing's getting into the heart, then nothing can come out of the heart. So how do you think the body responds to this drop in pressure? Well, the baroreceptors are going to sense hyperperfusion, and they're going to ramp up the sympathetic response, an effort to increase the systemic vascular resistance. Now, how exactly is this done again? There you go. The sympathetic response is driven by epi and norepi, and these are going to act on the alpha-1 receptors on blood vessels, leading to vasoconstriction. And now this increased vasoconstriction will lead to an increase in your systemic vascular resistance, or your afterload. Now this vasoconstriction of the dermal capillaries will make the patient feel cold, and the sympathetic mediated stimulation of sweat glands will make the patient feel clammy. So with all that said, what's the primary problem in hypovolemic shock? There you go, just not enough volume, and that's exactly how you're going to treat it. Replace what was lost. Either blast them with IV fluids, or give them blood, whatever you need to do to restore their intravascular volume. Alright, so next up we have cardiogenic shock, and it results in an increased central venous pressure, or pulmonary capillary wedge pressure, as we see here, a low cardiac output, and increased systemic vascular resistance. Now, cardiogenic shock is usually due to problems intrinsic to the heart, such as dying myocytes, conduction abnormalities, or valvular abnormalities. Now, some examples of this would be an acute myocardial infarction, heart failure, arrhythmias, or valve failure. Now, regardless of the cause here, the predominant issue is the drop in the cardiac output, and then the body attempts to compensate by activating the sympathetic nervous system to increase systemic vascular resistance. Also, due to this drop in cardiac output, blood's not going to move out of the left ventricle as well. This will increase your pulmonary capillary wedge pressure, as you can see here. Now, as we stated earlier, this increased sympathetic tone will make you feel cold and clammy. And just remember here, it's the alpha-1 activation that causes vasoconstriction to increase your systemic vascular resistance. Now, how about treatment? Well, you obviously need to address the underlying cause, whether that's an arrhythmia or an MI or whatever the situation may be. For arrhythmias, they may need some form of cardioversion or an antiarrhythmic, and for acute MIs, they likely need to go to the cath lab for stenting, or they might need to have a CABG. And if it's decompensated heart failure, they may need diuresis with something like furosemide to decrease the volume overload, as well as they may need inotropes like dobutamine to improve the cardiac output. Alright, next up we have obstructive shock. Now, obstructive shock is secondary to an extrinsic factor, such as blood compressing the cardiac chambers and cardiac tamponade, or in a massive pulmonary embolism, the clot preventing the right ventricle from pumping blood forward. So in obstructive shock, what do you think the cardiac output would be? There you go, it's going to be very low, because of the obstruction. Now this obstruction can cause an increase or a decrease in your central venous pressure, or your pulmonary capillary wedge pressure. Now, if the obstruction causes blood to back up from the left heart to the right heart, this is going to increase our central venous pressure. But if the obstruction prevents blood from returning to the right side of the heart, this will decrease pulmonary capillary wedge pressure. Now, can you think of an example that would result in a high preload or a high central venous pressure? Here, the fluid-filled pericardium compresses both the right and the left ventricle, leading to backup of blood from the left ventricle into the right. Neither the right or the left ventricle can fill adequately, therefore blood continues to back up in the venous system. This is going to cause the elevated pulmonary capillary wedge pressure, or preload, as you see here. And now while we're on it, what's Beck's triad for cardiac tamponade? Great, that's going to be distant heart sounds, JVD, and hypotension. Now what about a saddle PE or tension pneumothorax? What do you think these would do to your pulmonary capillary wedge pressure, or your preload? Well, in a tension pneumothorax, blood's not going to be able to get to the right ventricle. And in a saddle PE, blood's not going to be able to get out of the right ventricle. Therefore, if we were able to check the preload, or the pulmonary capillary wedge pressure in these cases, it'd be very low. So how exactly does this happen in a tension pneumothorax? Well, as you know, in a tension pneumothorax, air goes into the chest, and this is going to push the mediastinum as well as its structures to the opposite side of the chest. This is then going to kink off the superior vena cava as well as the inferior vena cava, which are returning blood to the right side of the heart. This in turn will result in the decreased preload or the decreased pulmonary capillary wedge pressure we talked about earlier. Now both in a PE as well as a tension pneumothorax, do you think you would have JVD? Well, the answer here is actually yes, you would. You will see JVD because blood is going to back up prior to entering the pulmonary circuit. And this is either due to the pinched off superior vena cava in a tension pneumothorax resulting in JVD, or due to the blood not being able to leave the right ventricle in a huge PE, which results in JVD. Now, regardless of the cause of obstruction, the cardiac output is going to be low. And when the cardiac output is low, the body's going to attempt to compensate by activating the sympathetic nervous system to increase your systemic vascular resistance. Now, this is the same response we see in any cause of decreased cardiac output. So the patient will have an increased systemic vascular resistance, and they'll be cold and clammy on exam due to peripheral vasoconstriction. Now for treatment here, the primary goal is to relieve the obstruction. If the cause is a tension pneumothorax, you're going to do needle decompression followed by a chest tube. And if it's a large PE, you may give TPA or place them on anticoagulation. And if it's cardiac tamponade, you're going to give IV fluids and they may need a pericardiocentesis. Now next up we have distributive shock, or vasodilatory shock, and this is due to a severe drop in the systemic vascular resistance. The classic causes here are sepsis, anaphylaxis, as well as CNS injury. And despite the different etiologies here, the main initial hemodynamic problem is all the same. It's diffuse vasodilation dropping the systemic vascular resistance. Now this will mean that we have different exam findings compared to hypovolemic as well as cardiogenic shock. Now these patients have dilated blood vessels, so therefore they feel warm and dry to the touch. The body is also going to compensate for this low vascular resistance by trying to increase cardiac output, and it typically does this by increasing the heart rate. One caveat to this is in CNS injury, this can lead to decreased cardiac output as well as a decreased heart rate and decreased systemic vascular resistance. And this is due to loss of autonomic tone seen in severe injury. Now once again, it's important to remember that this is not every case of CNS injury. This is just some cases of CNS injury. The big takeaway here is that CNS injury results in vasodilation, which results in a decrease in your systemic vascular resistance. And that's the point we're trying to make here. So how do you think we would treat distributive shock? Well, we give IV fluids to attempt to increase the cardiac output as much as possible, as well as give pressors to counteract the vasodilation. So what type of pressors do you think we'd use? Well, in septic shock, you use norepinephrine, and if it's anaphylaxis, you're going to go with epinephrine. And now while we're on it, let's talk a little bit more about sepsis and septic shock. Now this is something that you're going to encounter daily when you're on the wards, so knowing this info can really help you stand out on rounds. Now before we have sepsis, we actually have something called SIRS, or Systemic Inflammatory Response Syndrome. Now SIRS occurs when there are local inflammatory mediators around that spill over into systemic circulation and cause diffuse effects. It can occur due to infectious as well as non-infectious inflammatory processes, such as acute pancreatitis, as well as pneumonia and meningitis. And the results of this systemic inflammation are how we diagnose this condition. To be diagnosed with SIRS, you need 2 or more of the following. So you either need a fever with a temperature greater than 38 degrees Celsius, or you need to be hypothermic with a temperature less than 36 degrees Celsius, or you need to be tachycardic with a heart rate greater than 90, or tachypnic with a respiratory rate greater than 20, or you need to have a leukocytosis greater than 12, or a leukopenia with a white blood cell count less than 4, or a bandemia with greater than 10% bands. Now each of these is its own group, and you need 2 of the 4 to be diagnosed with SIRS. Now sepsis is diagnosed when we have SIRS plus a confirmed infection. An example of this might be a patient with pneumonia. They're coming in with a fever, they also have an elevated heart rate, as well as an elevated respiratory rate, and their white blood cell count's up. They're going to meet the diagnosis for sepsis because they have a confirmed infection with pneumonia, as well as they have greater than 2 of the SIRS criteria. Now, if we go on to have organ hypoperfusion despite fluid resuscitation, this gives us the diagnosis of septic shock. Alright, before we wrap it up here, one last high yield principle. Often, the first sign of shock is tachycardia. This is because as the blood pressure begins to drop, the fastest thing the body can do to try to restore cardiac output is increase the heart rate. Alright, well that's going to wrap us up. See you in the next video.